Hello, my name is Mariana Russo, and I will be presenting on panic disorders. Also, I'd like to apologize if there's any background noise. We're at a hotel for Thanksgiving, and there's no quiet space to record this. So with that being said, we'll get started. Dave is a 41-year-old male who was referred by his primary care physician after presenting to the ER with difficulty breathing. Dave's physician was unable to find a medical explanation for his symptoms, which left Dave feeling confused, stressed, and angry. Over the last 6 months, Dave has had several instances where he felt an intense fear that would reach a peak within minutes. During these instances, he would also experience sweating, heart palpitations, chest pain and discomfort, and shortness of breath. At times, Dave worried that he might die. As a result, Dave has persistent worry about having another attack. In addition, he has begun to avoid unfamiliar places and people where it may be difficult to get help in the event of another panic attack. The panic and associated avoidance are significantly impacting Dave's life as he has been turning down social invitations, making excuses to stay at home whenever possible, and relying on his wife to drive their children to their various activities. Although she was understanding at first, Dave's wife has grown frustrated with what she perceives as his irrational fear of panic attacks. The DSM-5 defines panic disorders with 4 criteria. A, recurrent unexpected panic attacks, which is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or more of the following symptoms occur: palpitations, sweating, trembling, sensations of shortness of breath, feeling of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, chills or heat sensations, derealization, fear of losing control or going crazy, and fear of dying. B, at least one of these attacks has been followed by 1 month or more of one or both of the following: persistent concern or worry about additional panic attacks or their consequences. And this can include losing control, having a heart attack, the going crazy bit again, and also a significant maladaptive change in behavior related to the attacks, which are behaviors designed to avoid having a panic attack, such as avoidance of exercise or unfamiliar situations. And C, the disturbance is not attributable to the physiological effects of a substance or other medical condition. So drug abuse or medication or another medical condition such as hyperthyroidism or cardiopulmonary disorders are also sometimes mistaken for this disorder. And lastly, D, the disturbance is not better explained by another mental disorder. There are some specific qualifications listed under section D that you can read on the slide as well. So here is the 5 A's model of behavior change in primary care that I will use to facilitate this treatment plan. The 5 A's are assess, advise, agree, assist, and arrange. The assessment portion of this session will take the majority of the time. It includes an introduction of the behavioral health consultation, clarification of the client's presenting problem, a functional assessment of the problem, and the clinician's summary of the problem. The main goal of assessment is to determine if the client meets criteria for a panic attack and how they change their behavior because of it. To assess for panic disorders, the clinician asks targeted questions about experiences with panic-related symptoms, such as, have you ever had an episode when you suddenly felt your heart racing, had difficulty breathing, started feeling shaky or dizzy, or were you worried that you might die, suffocate, or have something bad happen? How long did that episode last? How many experiences have you had like that? Were you worried that it would happen again? Did you change what you did because you were concerned about the attacks? Have you avoided places that might be difficult to get out of or might be embarrassing if you had one of these attacks? And what do you do to avoid having an attack? Have you avoided driving and other activities that might have been altered because of this fear, including social gatherings? Dave experienced symptoms of agoraphobia, which is the fear and avoidance of places that the individual thinks would be difficult to escape or find help in the event of developing panic-like symptoms or other incapacitating symptoms. This can be diagnosed irrespective of the presence of a panic disorder. However, Dave experiences symptoms that also meet criteria for a panic disorder. Dave meets criteria as his panic symptoms reach a peak within minutes, and he experiences at least 4 of the symptoms, including sweating, heart palpitation, shortness of breath, chest pain, and fear of dying. He has experienced persistent concern of future panic attacks, as well as experiencing maladaptive changes in behavior related to the attacks, such as social isolation, avoidance of certain places, staying home when possible, and heavily relying on his wife to get their kids where they need to be. These symptoms are not attributable to substance use, other medical conditions, or other mental disorders. Risk factors include temperamental factors such as negative affectivity or neuroticism, anxiety, sensitivity, and a history of fearful spells, which are limited symptom attacks that did not meet full criteria for a panic disorder. Dave exhibits a propensity for anxiety sensitivity in particular, as evidenced by his reported fear of dying from his symptoms. Environmental factors are experiencing sexual or physical abuse, smoking, and interpersonal stressors. None of these have been reported for Dave, but we do not have much information about any possible causes to the onset of his symptoms 6 months ago. Genetic and physiological factors include increased risk for panic disorder among offspring of parents with anxiety, depressive, and bipolar disorders. This information was not provided in the case study, so further information about family medical and psychiatric history is needed to shed insight into the case. However, even without knowledge of this and other risk factors, Dave meets criteria for a panic disorder. One listed symptom for Dave is suicidal ideation. According to the DSM-5, panic attacks receiving a diagnosis of panic disorder in the past 12 months correlate to a higher rate of suicide attempts and suicidal ideation, even when comorbidity and a history of child abuse and other risk factors are taken into account. Lastly, Dave's panic symptoms and not finding an answer from his primary care physician has led to anger, confusion, and stress. For his wife, as mentioned, she perceives these fears as irrational. The GAD-7 and GAD-2 are also useful screening tools for panic disorders, as well as 5 questions from the PHQ that are shown in the picture. So they're simple yes or no questions, which can be confusing as some of these have somewhat stacked questions. For instance, number 1, 2, 3, 4, 5. Number 5, where it asks if they've experienced symptoms like shortness of breath, sweating. I know I would have a difficult time taking this because I'd be like, well, what if I have one and not the other? And so this can obviously create some confusion as well, but as far as screening goes, it can be a useful tool. Advise. A diagnosis and subsequent treatment will hopefully put Dave's frustration and stress to rest, as well as inform his wife's perspective now that he has received a diagnosis. One major goal of treatment will be for Dave to be able to resume his responsibilities with his family that he had prior to the onset of panic symptoms, which will aim to address his wife's frustration as well. In addition to biomedical treatment, which typically involves SSRIs, there are 3 recommended psychosocial treatments for panic disorders: applied relaxation, CBT, and psychoanalytic treatment. Applied relaxation has the goal of getting individuals to quickly relax during stressful situations by using progressive muscle relaxation. First, the client identifies early panic cues in situations where panic symptoms are likely. The relaxation techniques are practiced in sessions in the presence of panic cues and eventually in real-world situations in which panic is likely. Thus, many of the behaviors Dave has as a result of agoraphobia and panic symptoms will be reduced, as he will be able to address the symptoms immediately with this technique. This would help him cease social isolation, sorry, I'm having difficulty with that word, and responsibilities that cause him to leave the house. CBT helps clients identify, challenge, and change dysfunctional ideas related to panic symptoms. Avoidance of panic and panic cues is specifically targeted using exposure exercises. This includes things such as going to places where Dave feels he cannot escape or get help quickly if he were able to experience panic symptoms, as well as dealing with the physical impact of symptoms, such as his heart palpitations or shortness of breath. This is called introspective exposure, and its goal is to help the client identify and recreate the bodily sensations associated with panic to then decrease fear and fear experience as a result of those sensations. Lastly, the goal of psychoanalytic treatment is to uncover the unconscious psychological meaning of panic. This treatment focuses on conflicts including separation and autonomy, as well as anger expression and anger management. This treatment uses transference to identify and work through these unconscious conflicts. The research support for this intervention ranges from controversial to modest, as the conceptual basis has not been tested. Psychoanalytic treatment has been tested and has been effective, but it is yet to be proven if this treatment effectively reduces unconscious conflict. After discussing the interventions with Dave, he would decide which he believes would work best for him or which he is most agreeable to do. This is a client-centered decision that the client will make after the clinician has provided as much education about each intervention as possible, answering any follow-up questions the client may have about each one. Motivation would also be discussed as a precursor to setting goals to start helping Dave think bigger picture. How could this treatment impact his life for the better? What would it look like to have a way to handle these panic symptoms? And what would he be able to do if he were able to effectively handle the symptoms? These methods would help alleviate his symptoms, particularly fear of death, as those fears were a result of being unable to control bodily sensations that accompanied his panic symptoms. These fears, alongside his agoraphobia, prevented social interaction and responsibilities that caused him to leave the house. Thus, after treatment, the goal is for Dave to be able to resume some of his normal activities and higher quality of life prior to the onset of his panic symptoms. Goal setting is a collaborative process, but it is still client-centered. Motivational interviewing can also be used to elicit goal setting from Dave and encourage him to make concrete statements for treatment planning. It is important to explain the buy-in from the client. For example, if Dave chooses to engage in CBT, it can be very beneficial for managing panic symptoms long-term, but he must first be willing to tolerate the uncomfortable physiological symptoms that occur with anxious thinking. And with relaxation, he must be willing to practice this new set of skills for it to really be effective. On to the assist. The assist portion consists of providing education, teaching skills such as managing their alarming thoughts, and teaching relaxation techniques. We begin by educating the client about their disorder. This could include things like handouts, as the one shown, to explain what's going on with their body when these symptoms happen. Especially for Dave, helping him understand that his symptoms are exaggerated sympathetic responses rather than any serious medical concern, since his doctor ruled that out, can help him conceptualize the disorder. Instead, Dave's fight or flight response, which usually helps people in dangerous situations, is seemingly activated for no reason, and the symptoms can feel overpowering. Then we explain that this is where we can apply CBT principles, for instance, of challenging those thoughts. What kinds of thinking exacerbate their symptoms? We can explain that our thoughts or fears about the symptoms can heighten the symptoms' intensity and frequency. Thus, we work on addressing those thoughts before they are able to escalate our symptoms. Oftentimes, the harder one tries to control their symptoms, the worse it gets. So we work with clients to be open to the possibility of letting the symptoms occur and relax the body, knowing that our symptoms will go away with a little time. We would go over relaxation methods further using techniques like controlled breathing. This can help replace responses such as hyperventilating or overbreathing. Applied relaxation also entails identifying early panic cues in situations where panic is likely, so the client will be prepared to undergo the relaxation techniques when needed. Situational exposure can help desensitize the client to places, people, or objects the client avoids out of fear. As Dave experiences agoraphobia, this could particularly help him resume normal life. It involves having him come into contact with each of his fears with a set time of exposure. A situational exposure hierarchy, which is pictured, can be given to a client to self-complete. This will help the clinician get an understanding of what situations they're dealing with and be able to formulate a plan for exposure. Lastly, interoceptive exposure, I think that's correct, focuses on desensitizing clients to their feared bodily sensations and responses. For instance, Dave experiences heart palpitations, which can be recreated by breathing through a straw for 2 minutes. Thus, we can help clients learn that their feared prediction about what might happen to them is not true. Finally, we will set a schedule. This will ensure the client doesn't fall through the cracks and is already set up to begin treatment. Dave will be sent phone or email reminders, whichever his preference is, to ensure he remembers his appointments. Lastly, we will be in contact with Dave's PCP to ensure that they are up to date with his treatment plans. Often clients with panic disorders improve quickly, but they can be referred to a specialty mental health clinic if their symptoms do not improve or if there are comorbid disorders that complicate panic disorder treatment. Ideally, the mental health clinician they are referred to should be trained in CBT for panic disorders, as it has been proven to be most impactful, especially since not many other treatments have been effectively tested for panic disorders. There are a slew of additional resources that can be combined with any treatment that the client chooses. The image in the slide provides some examples of a website or multiple websites, mobile device applications, and self-help books. For websites, the Anxiety and Depression Association of America and National Institute of Mental Health sites can help educate and provide more resources. There are also several apps that include walking patients through things like deep breathing exercises, mindfulness, and CBT strategies to lower anxiety, stress, and depressive symptoms. These apps include Breathe to Relax and Pacifica. And lastly, there are several books listed to help patients manage anxiety symptoms and use CBT skills to reduce worry, involving a step-by-step guide for targeting symptoms. I hope you all have been able to hear me okay with all the loud hotel things going on, but I hope you enjoyed this presentation, and that is all I have.